Good morning, everybody. It's lovely to be amongst friends and colleagues in person, but also online. And thank you very much, David. We're going to be hearing a lot about the achievements of the ISCF Digital Innovation Programme today. So I thought, rather than talk about the specifics of the programme itself, I would take advantage of having been part of this ecosystem along with yourselves for the past 14 years and look at where we are and where we're going, a longitudinal view of the UK health data landscape. So in my allocated time, which I'm not quite sure what it is because the timer doesn't align with the programme, so hopefully someone will stop me if I talk for too long, I'm going to look at what we've done so far, what we would like to achieve, and importantly, the lessons that we need to learn in order to get there. So what have we done so far? When I arrived at the Medical Research Council as the new head for health informatics, I was terribly excited. Gosh, perhaps we can use health data for a lot of applications. How exciting. But in the office, on the shelf, was a book written 40 years before, 40, by the Chief Medical Officer on health data linkage. Perhaps I wasn't the first to come up with that idea. But surely now the data was electronic. This was a real chance for scope and scale. Wrong. Someone had got there 2 decades before me. Back in Essex in 1988, when electronic health records were just starting in primary care, a GP thought, wouldn't it be a good idea to use this data to study the health of my patients? I'll see who else is interested in doing that. And so he linked up with another 20 practices, and before you know it, the genesis of CPRD was born, and it continued to develop over the last 34 years. I was extremely privileged to be director of CPRD for almost 7 years, and during that time, the data expanded fourfold, and we're now up to over 3,000 publications, all based on longitudinal primary care data. I hear talk of let's find some case studies to demonstrate impact. I feel confident if you look on the website, out of those 3,000, you'll find 1 or 2. Back in the mid-noughties, we decided to push on to see if we could use data for health research. This particular, Sir Mark, I don't think is here at the moment, but of course, Sir Mark, when he was in charge of the Wellcome Trust, was a huge advocate of health data and sponsored this conference, Frontiers Conference, bringing together leaders around the UK to think, how could we use health data and what do we need to do? I was at the UK Clinical Research Collaboration at the time, and we did some simulations. Could we use electronic health data from this new Connecting for Health programme for clinical trials, observational epidemiology, perhaps to prospectively track cohorts? The answer was yes. Even Nature was getting in on the act. Big data was coined, that phrase, because we had a lot of data now coming from genomics. At the MRC, we wondered what we could do, but so did Wellcome Trust, so did BHF, so did NIHR, so we thought it was much better to club together, always best to work in collaboration. But what should we do? This report that no one has ever seen and virtually no one has ever read is probably one of the most important reports and the genesis again of why we're here today. Because what we did was have a look at what needed to be done to strengthen health research capacity and capability in the UK. And there are many sitting in the audience who contributed to that report. And the funders decided it was important to work together rather than in isolation, and there was a great deal of strength in doing so. That was in 2011. The aspirations of the e-health centres, which is what we decided to fund at the time, you'll look at here, from a paper that we presented to MRC Council in 2011 resonate with the aspirations of Health Data Research UK now. More money became available, and we renamed our e-health centres the FAR Institute. The problem with the FAR Institute was not the outputs, and in fact, it did what we hoped it would do and built capacity. And this is a figure from a paper after the funding for the FAR Institute had finished. The figure on the left depicts the number of authors who were collaborating at the start of the FAR Institute, and the figure on the right shows the inter-FAR Institute collaborations by the end of the initiative. So we felt that we had started to make a real contribution towards building capacity. But the problem that we had on a strategic level with the FAR Institute was that it was set up in competitions. We had 4 centres all competing together, and while we had a network chaired by Andrew Morris, they were still never meant to align. So the natural next step was to form a single institute, also supported by largely the same funders, and so Health Data Research UK was born, with a combined mission to improve the landscape in the UK. In 2013, ABPI released a report, and the report there on the left, the roadmap, Big Data Roadmap, illustrated how important UK health data was for industry. And this theme was picked up in 2017 in the Life Science Industry Strategy, which gave birth to the funding for this very programme that we're here today for. There are 3 components of the programme. This is the same slide that David showed, and I imagine it will be shown several times today. And we'll hear more about the hubs, the gateway, and the alliance during the day. So what would we like to achieve in the future? Well, we'd like to achieve a joined-up informatics landscape. We need to do that through funding, enabling technologies, and building capacity. I'd like to say that I produced this slide for this conference. Wrong, I produced it in 2009 when I was at the MRC. And yes, we have made some strides, but we're not quite there yet, are we? There's more to do. And if we look at the landscape now, although we have made some strides, it's actually more complicated. We've got more data, now we've got in silico as well to add to the complexity. And we still haven't really sorted out how to access. We still don't have access to all the electronic records across the UK in the way that we need to for research. And so the aims still remain to have a UK-wide secure infrastructure which facilitates and enables research for all. We need to continue to grow capacity. We need to have the right tools to support research. And crucially, we need support from the public, patients, and healthcare professionals. So how do we get there? Oh, hopefully we get there by, great. We're all familiar with pictures like this. When was this article published? Anyone like to have a guess? I'm going to pick on my own team unless someone say. Tim. 2013. But it could have been published last year. In fact, very similar articles were published last year. And while I was director of CPRD, I had phone calls from the press office on 2 occasions on the weekend because there were articles in the Observer attempting to scandalise what in fact we were doing, which was the correct thing, providing data in a safe, secure way for industry. So is it possible to win the media over? The answer is yes. This is the same newspaper that produced some of those articles that were on the previous slide. Even Polly Toynbee was supportive. It is possible. If you have productive conversations, if you're transparent about data use and you explain, it is possible. So this is where we need to go. Another absolutely essential lesson that we must learn comes from care.data. So I was on the board of care.data after it was paused and before the whole program was pulled. Now, the importance in that was that I wasn't part of the NHS establishment. I was at the MHRA as Director of CPRD. Now, why was it important to not just have friends on the board? Because I pointed out to them that if they went ahead with their plans to restrict the data sets that they were collecting, collect once, use multiple times, you wouldn't be able to use it multiple times. In fact, you'd bring research to a standstill. And to prove the point, and encouraged by the board, I went back to the CPRD team and we did an analysis of high-profile studies, that is, those that had influenced policy and were in the top-ranking journals, to see how they'd be impacted if the timeframes were restricted to 6 years or 12 years, if certain codes were removed, or indeed if certain conditions weren't included in the data set. Over 90% of the studies would be impacted. So what's the importance of this? The importance of this is you must have those who are using the data as part of the conversation as we set up any infrastructure. So in conclusion, these are my take-home messages. So this is me speaking from my own personal experience here rather than as challenge director. We've been working on this for some time, and we've been working together, and we need to continue to work together. So that's the first point. If you think it's new, you're wrong. We must understand what hasn't worked before and don't repeat it. I'm going to say that again. We must understand what hasn't worked before and don't repeat it. Conversely, we must listen to things that are working well, not ignore them, and learn from them. And we must not ignore what researchers need in order to carry out the vital science that they do. And finally, we must value all of our assets, including, no matter where it takes place in the UK, if we're going to really bring all of this together. And I'm just going to use this opportunity to give a big shout out to Birmingham, and thank you very much for hosting us. Birmingham do absolutely fantastic science. We've got 2 of our hubs here. There's also a really fantastic trial going on using health data to model recruitment, and it's a decentralized trial. Isn't this something we've all been talking about? Why isn't it on everybody's slides? So I'm going to leave you with that thought and pass back to David. Thank you very much.